Tuberculosis is a global emergency, and Dr. Wali said 1.3 million people die of tuberculosis every year, and India almost 500,000 people dies because of tuberculosis. It is the main death because of lack of proper diagnostic methods and lack of new drugs. So my topic is recent advances in tuberculosis. So I divide my topic in three parts: recent advances in TB diagnostics, recent advances in treatment, and in prevention. So what progress we have made from past to present? The tuberculosis bacilli was diagnosed 127 years back by Robert Koch, and from the this invention or diagnosis of tuberculosis bacilli till now, the main diagnosis is symptom, tuberculin test, egg-based solid media, and X-ray, which were diagnosed around 100 years back. Even now, it is major. This is the diagnostic method. Sir Rontgen, who diagnosed X-ray in 1895, and he was given first Nobel Prize. In the beginning of 20th century, for 30 to 40 years, fluoroscopy remained the main diagnostic methods, and X-ray film came quite later. The trend of MMR came in 1940, and the gentleman is Greyfield Hausenfeld, who invented computer tomography in 1972, and it still remains modality in diagnosis of tuberculosis. The tuberculosis skin test, the commonly known as Montauk test. So tuberculosis skin test is one of the common method used to diagnose latent tuberculosis. But it do not tell about a difference between latent tuberculosis and active tuberculosis. Also, there are chances of false positive BCG because of previous BCG. So the study was done. In study shows when the BCG was given after the infancy, the chance of false positivity was 40%, and when it was given before infancy, the chance of false positive tuberculin test was 6%. The improved version of tuberculin was E-stat skin test, where the antigen was PPD was RD-E-stat 6, but it is not endorsed by WHO till now. The latest one is interferon gold test, which is in vitro assay. So this was wrongly promoted as a test for diagnosis of tuberculosis. But this test do not tell us a difference between latent tuberculosis and active tuberculosis. The principle of this test is that we incubate patient blood with the PPD like E-stat 6 or CFF10, and we incubate for 12 hours. And after 12 hours, we quantify the level of interferon released by T cell of patient blood. So this is more quantified and accurate test and replacing skin test in most of the countries. But the problem is this is not good test in HIV patient and in children. The sputum microscopy. Sputum microscopy was diagnosed in 1882 by Robert Koch and still being used all over the world for diagnosis of tuberculosis. This is one of the rapid method and accurate method, but low sensitivity. The sensitivity of test is almost 45%. So the other one is fluorescent microscopy. It has enhanced the sensitivity level to 10%, almost 55%. And the latest is lead microscopy. The lead microscopy had drastically increased the sensitivity of sputum microscopy. The sensitivity is about 70 to 80% with the lead microscopy. But the problem of the initial cost of microscopy is very high and beyond the reach of peripheral level. Then conventional culture method. It was used in 1882 it was started, but it takes 3 to 4 weeks for development of tubercular bacteria growth and another 4 to 5 weeks for drug diagnosis. Now latest one is liquid culture method based methods, which can be semi-automated or automated. The semi-automated methods are like Bactec 460, Septicheck AFB, manual MGIT. The auto methods like alert method, then Backtech 9000. Then many other methods are under progress like Bursa-Track, thin layer agar methods, mods, colorimetric methods, or direct nitrate reduction assay. So in Backtech 460, the principle is metabolism of radiometric carbon. So bacteria use that palmolic acids and release carbon dioxide, and that radiometric carbon is diagnosed by these machines. But the problem is handling of radiometric material. Then MGIT methods is a very good method. The here principle is that oxygen quenched fluorescent dye being used. So when bacteria use that oxygen, and then a reduced dye give fluorescent colors. But again, it's a labor intensive methods, need lot of investment and beyond the reach of developing countries. Now new development is molecular methods. Here principle is target on the PCR. The main system is like target amplification, signal amplification, probe amplification, or auto method methods. So main auto method methods are like ampliclor methods, amplified MTD methods, LAMP, gene expert, or line probe assays. So gene expert is one of the best methods till now. That is the first major breakthrough since sputum microscopy, because a result come in 2 hours. It is fully automated methods. The yield in positive sputum is 99 to 100%. In sputum negative, it is 57 to 83%. And even in extrapulmonary cases, the yield is 81.3%. Then Haynes method or gene MTD and DVDR assay methods. Here the principle is DNA extracted from the sample material, which can be sputum or from the culture, and they are detected after reverse hybridization and enzymatic color reaction on the DNA strip. So it's two type, MTV-DR plus or MTV-DR-SL. In MTV-DR plus, it help in diagnosis of first line drugs, especially rifampicin and or isoniazid. And MTV-DR-SL, it help in diagnosis of second line drugs like fluoroquinolones, aminoglycosides, ethambutol. So help in diagnosis of XDR tuberculosis. So this is how this method is being done. Then serological methods. In last few years, so many serological methods were done. But it shows that inconsistent and imprecise sensitivity and specificity. So WHO and Indian government banned serological methods in 2012. So it's now no more being done and no strips are being imported. This is a series released by WHO for all diagnostic methods. So till now, endorsed methods are like liquid culture based, which is alert 3D method or MGIT. Then automated reactions are like gene expert. Then line probe assay, which can be MTD direct or Lino, Inno, LIPA, RIF, TB, or strip specification like capillary TB rapid diagnostic test. Then a new few methods are coming up like urase breath test, urine lamp assay, e-nose, optic, superoxide, and more. But interesting is urine lamp assay. So in urine lamp assay, what can be done that a strip can be put in patient urine and it can immediately tell if patient tuberculosis or not. And even the urase breath test, here patient have to blow in the machine and from the breath we can get to know if patient have tuberculosis or not. But still in the developing stage. This is algorithm, I'm skipping. So what progress we have made? So progress we have made from the skin test to the interferon assay test, from the simple microscopy to lead-based microscopy, from simple culture to liquid culture. So now what treatment have been done in the treatment of tuberculosis? So in Indian perspective, WHO and strategies for 2014 to 35 is that there should be zero mortality in 2035. But for that, we need a shorter treatment, affordable care, novel diagnostic and prevention care. Some few drugs were introduced for treatment of MDR or exterior tuberculosis, that bedaquiline, delamanide, protamide, sutazolid, or SQ109. The bedaquiline, it is marketed by the name Suturo. So it took almost 40 years for the this development of this drug. So this drug acts by inhibiting ATP synthesis. So this inhibiting the energy released by the mycobacteria. So dosage is 400 milligram daily for 2 weeks, then 200 milligram thrice a week for 22 years. So it acts on both active and dormant bacteria, both in drug sensitive and drug resistant bacteria. So this is approved in US FDA December 2013, but not approved in European market or in India. So bedaquiline, it was shown that it increased the QT interval. So patient need to do constant EC monitoring and LFT. Then delamanide. The delamanide is approved by European market in November 2013. So it acts by inhibiting mycolic acid synthesis and synthesis of bacterial cell wall. The recommended dose was 100 milligram BD for 24 weeks. So again, these are not approved in US market and in India. So these are some of drugs, how they act. Delamanide, this SQ109 and protamide, they act by inhibiting cell wall synthesis. Bedaquiline by inhibiting ATP synthesis, and sulazolide, which act by inhibiting protein synthesis. Then moxifloxacin. So it was introduced as an alternative to INH or ethambutol, and it was proposed that it can decrease the duration of treatment to 4 months. So trial was done to check out. It was RE-MOX TV trial where moxifloxacin was replaced for ethambutol or INH in initial or continuation phase. So the conclusion was that it can be replaced to both the drugs, but the proposed theory that it can treatment can be shortened was wrong. So standard treatment was 6-month treatment minimum. Again, a STAND trial was done. So STAND trial was they give this protaminate, moxifloxacin, and PZA as a replacement of MDR treatment for 6 months. So this trial is still undergoing, and this because in MDR treatment the treatment requires 18 to 24 months. So it was proposed that it can shorten the treatment by 6 months. The other novel trials which are still undergoing is like the one trial is bedaquiline, moxifloxacin, protamide or paraginamide. Then another trial clofazimine, bedaquiline, protamide, paraginamide. So then another trial was proposed as a 24 conventional treatment to 6-month treatment of levofloxacin, linezolid, paraginamide, ethionamide or bedaquiline. So it was proposed that this 6-month treatment can be used as a treatment for MDR tuberculosis. Now rifampicin. So rifampicin, when it's used, it causes a lot of problem like GI intolerance and hepatitis. So rizorin, it was introduced in the market as an alternative to rifampicin, conventional rifampicin, and it was proposed that making the half dose of rifampicin by rizorin, there can be sustained level and improve GI tolerance and decrease hepatitis. So now advancement in the prevention of tuberculosis. So for prevention we have BCG vaccine, but this vaccine acts only at a pre-infection level. There is no vaccine at latent or active disease. So various vaccine was introduced like which can replace BCG or which can give booster effect to BCG. But the main vaccine in the advanced stage of development is ARAS 402 and MBA 85A, which can act as a BCG booster. So in summary, that still we not have any main method which can be affordable to peripheral level. But the best rapid diagnostic method till now is GeneXpert or MTD method. And the new drugs which are introduced can probably decrease the duration of MD treatment to 6 months. And the proposed theory that 4-month treatment can be effective is wrong. A minimum 6-month treatment is still a gold standard. Thank you very much.